Hi, I'm Dr. Mark Studin. Together with ChiroSecure, we're going to bring you some really cool information today about herniated discs. And by the way, I just want to also thank ChiroSecure for giving me this forum to share so much about chiropractic and spine with you on a regular basis. It's an unbelievable forum and opportunity to learn, and something we all should be appreciative for. And again, I just want to thank them. So what we're going to talk about today is herniated discs and etiology. Now, when we look at herniated discs in etiology, we have to understand what a herniated disc is. And when we look at what a herniated disc is, it's when the inside nucleus pulposus material goes on the outside. It's really, this is the nucleus pulposus, this is the annulus fibrosus, basic morphology. When there's a tear or rent in the annulus the nucleus goes out and it goes beyond the vertebral end plates. So anytime it sticks out, that's a herniation. And it's defined as a localized or focal displacement of disc material beyond the limits of the intervertebral disc space. And it's really easy, and I give you a little bit more a definition on here in words, but I also give you a reference from Fardone, and it's a 2014 article, which is still the industry standard. So I urge you to go get that article. Now, when we look at a herniated disc, anytime the inside comes out, and we've got that little starred piece here, and I've colorized it or filled it in, this is the inside nucleus pulposus material coming out. And by the way, if you look here, this is the annulus, this is the nucleus. You could see here there is a conduit, and this is called an annular fissure or a tear in the annulus. And that really happens predominantly with trauma. And some people say there's a normal progression or a natural progression of disc herniation. You know, you need an initiating event. The natural progression is degeneration. Then you have tear. Now, or there's no degenerated evidence here, but you have evidence of a fissure, and that's your evidence of trauma. So if the herniation could be less than 25% of the circumference, and that's called a focal herniation. If it goes 25 to 50% of the circumference, that's a broad base herniation. Now, you would think intuitively that broad base is more egregious than focal because it has more volume on the outside. But the arbiter between good and bad is the neurological compromise as sequelae to the disc herniation. And typically, focals stick out further and compromise the neurological element more so than the broad bases, making these potentially and usually more egregious. Now, when we look at it, here's a sample. This is called the sagittal view. This is the axial view. And look here, I've colorized in red right here for you. That's your focal herniation. Here I've colorized in gold, herniation, focal, less than 25% of the circumference. Now here, when we look at it again, here's another focal. And I did this is a T2 weighted image. We're looking right here. Hard to see, but we go to a T1 weighted image. Right here, you could see it sticking out. And again, I've colorized it for you to show you. And when we look at the axial of the top-down view, it's sticking out right over here. And I've colorized it, and it's not a whole lot. This is the spinal cord. It's not compromising the spinal cord, but there is a herniation which affects the recurrent meningeal nerve. It affects a myriad of other neurological things going on, which today's not the forum for that. Now what we look at is a broad base herniation, 25 to 50% of the circumference. And when you look at here, I've colorized this for you. This is greater than 25% of the circumference. And here's the opposing view. You always need two shots. This is the opposing view on the sagittal showing the herniation here. And we're looking at it right here from the opposing view. Just as a little side note, the spinal cord is being compressed because you cannot see CSF or cerebral spinal fluid in the front or back in both views, axial, and this is the sagittal view, one that most of you are less likely to understand. This more looks like an x-ray, so it's a little bit easier, and it's a kicking off point. Now, by the way, in this brief little tutorial, I'm giving you a soundbite. Do I expect you to be educated in a herniated disc? No. But hopefully, I could bring your education level up a little bit, or for many of you, just expose you to what you need to learn. And it's not hard. It's just a repetition issue. But I can tell you, if you would like collaborative relationships with medical providers, medical primaries or medical specialists, or orthos, neuros, neurosurgeons, pain management doctors, you got to know this stuff, and you got to know it well. If you ever want to have a meaningful relationship with an attorney, you have to know this stuff. But before I had any of those relationships, when I learned this, the biggest winner was my patient, because there is a 42.3% error rate with general radiologists correctly reporting disc issues, the morphology or shape or pathology of the disc. There's a 42.3% error rate. That's almost a 50% error rate from general rads, and you got to know that because you're relying on their report to deliver a high velocity, low amplitude thrust, which could hurt the patient if it's delivered and the information is wrong. Now, when we look at a protrusion is a herniation whose base is wider than the apex at any point, kind of like a pyramid. And an extrusion is a herniation whose apex is wider than the base at any point, kind of like a mushroom. So when we look on and we see here the protrusion, right here we look at the protrusion, the base is wider than the apex like a pyramid. So here's your herniation. This is a protrusion type herniation, and we could see the base is wider than the apex. Here's the base, here's the apex. That's a protrusion. But when we look at extrusion, which could be migrated or comminuted, comminuted means migrated, also known as comminuted, means it's attached. So this is an attached extrusion. This is a fragmented extrusion or sequestered, not attached. So when we look at an attached or comminuted extrusion, let's go right to the non-marked up. This is the reference point. Here's the disc, here's the bone, here's the bone, here's the disc, and it's coming out. Now, I could age date that, but that's a whole nother conversation to look at etiology. So what we do is we look at the disc space. So I put a line at the top of the disc space and the bottom of the disc space. Here's your disc space right here where it comes out. So if there's any material above or below, that's an extrusion. And this would be called an extruded disc that is mildly extruded caudally or superiorly, okay, a cephalad, or a large inferior or caudal extrusion or inferior extrusion at the disc level. And you could see how that clearly goes above and below the disc space. Now, here it is again. Here it is. Now I've colorized the image, and then I put the lines here for you to be able to see, kind of start to visualize. I know I'm going really fast, and I appreciate that, but I just wanted you to understand and look at concepts. So this is an extruded disc that goes both caudally and cephally and caudally. Keep saying that backwards or pointing backwards, but this is the extruded area. And you could see here, I'm not going to explain this now. This is a varix or an epidural vein. This is a posterior longitudinal ligament. This is not a spinal cord. This is your cauda equina. We know we're in the lumbar spine. So we know what's going on. And this disc is creating a moderate, actually a moderate narrowing or stenosing of the neural canal. So there's a lot going on, and it's not really hard to understand once you see a whole bunch of these. So here again, we're looking at another extruded disc. And this comes out, it doesn't go cephalad, but it goes caudal or inferior. I've colorized it for you, and then I've put the little lines there to show the disc space. So this is an L4-5 18 millimeter inferior extruded disc that is severely stenosing the spinal canal. There's almost no space left. And when the cauda equina comes in, it's being severely compromised. There's a lot going on here, folks. A lot going on. The disc ends here, and below that, this is called the varix or an inflamed epidural vein, which I'm not going to get into right now. It's just anatomy. And by the way, this is all the stuff we teach. We teach you all this stuff. It's not hard to learn. So you really need to understand all of this. Now, when we look at etiology, you got to be able to age date this stuff. Has it been there a long time? Is it old? Is it new? What's going on? Because that matters to diagnosis and then prognosis. Remember, it's diagnosis, prognosis, and treatment plan in that order. If you do not know, you do not touch. You got to know what's going on with your patient. Can you get them better? Is there a herniation? So here's the thing. Patient comes in and they have pain radiating down their arms or legs. What's wrong with them? Oh, they've got a radiculopathy. No. Radiculopathy is the radiculopathic finding is the sequela to what's going wrong. What's going on with them? Why are you touching them when you don't know what's going on with them? Is it a herniated disc? I don't know. Is it a bullet in their neck? I don't know. Is it a tumor? I don't know. Is there a fragment in there? If I adjust them, it's going to get, oh, I know I can get them well. I'm going to just start adjusting them. I know. No. You don't do that. That is highly irresponsible. Diagnosis first. Whoop. Diagnosis first. I don't even know why this just happened. Diagnosis first, prognosis second, treatment plan last. First, you diagnose your patient. I am an aggressive diagnostician. If there's a radiculopathic or myelopathic finding, and unfortunately, too many of you don't even know what the word myelopathy means. It means cord compression with ensuing neurological deficit distal to the level of lesion, or cord involvement with ensuing neurological deficit distal to the level of lesion. So these are the little things you need to learn which are critical. Forget personal injury. This has nothing to do with that. This could be that 70-year-old patient who walked in who just sneezed. It could be a 21-year-old kid who played sports or fell on their butt doing something. How do you know what you're treating if you don't look? Because you could hurt that patient badly. Remember the credo, doctor, do no harm. Yes, you want to help the patient. Diagnosis first, prognosis second, then treatment plan, in that order. And that is a hard mark rule, and please never forget it. So folks, if you want to learn this stuff, and by the way, these are some of my credentials, you can earn all of those. They're not hard to do. Okay, I'm a fellow. I've got a mini in primary spine care, a mini fellow in MRI spine neuroradiology and extremity. I'm trauma qualified, MRI qualified, primary spine care qualified, hospital. Every one of these I learn MRI. I learn triage. You learn all this stuff, and you should get the credentials for learning these things. You have to take continuing education. Make it meaningful. Make it something that will advance your career and help your patients at a higher level. You know who'll really like that? ChiroSecure, because they're the risk taker for you not getting that level of advanced education. They'll love this stuff. And by the way, I put up on there a QR code. If you could put that back for 1 second, just to show you that if you want to get credentials, take your cell phone out, take a picture of that QR code. You could learn all about MRI. It starts at a 3-hour course and goes all the way up to 400 hours. Take your pick. There's dozens of courses. So folks, listen. Thank you so much for giving me the few minutes to share this information with you. If you have any questions at any time, please call me. And again, ChiroSecure, thank you so much for this forum for all of us to learn.